Concussion update. So this one is basically a review of kind of what's been going on over the past couple years regarding the new concussion law and concussions. So our goals today, we're going to talk about what a concussion is, so kind of definition type of stuff, how to recognize a concussion. So if you're at an event, or you're, as a parent, you're one of your kids' events, what to look for, what to pay attention to. Common treatments, so if you do get a concussion or know someone who has a concussion, some common things they may try to do during their treatment plan. And then we'll talk about the Ohio Return to Play law, what that means. That started in April of last year. And we'll talk about what those requirements are if you do have a concussion or display signs or symptoms of a concussion and are pulled from a game. So first, the definition. The first one is basically where we talk about a traumatically induced transient disturbance of brain function. Now, this, the keys to this one is that it's generally self-limited and it's less severe on the less severe end of the brain injury spectrum. So you have your severe traumatic brain injury, car accidents, different things like that, compared to the less severe ones, mild traumatic brain injuries. That term was commonly used interchangeably with concussions. Now it's recommended that it's not, meaning a concussion is more of a sport-induced mild traumatic brain injury. It is a pathophysiologic process affecting the brain that is induced by biomechanical forces. The other thing that its common features are incorporate clinical symptoms that you would notice, pathological stuff that you wouldn't necessarily see on a physiologic basis, obviously, that result in the picture that you see of the concussion. The other keys to the definition that are common misperceptions, it is usually caused by a direct blow to the head or face or neck, but it can also be caused by a blow somewhere else on the body. So if you say, well, there's no way I didn't get a concussion because I got tackled and my head didn't hit anything, that's not necessarily the case. So it doesn't require a blow to the head. It typically is a rapid onset of a short-lived impairment, meaning it's usually the symptoms occur rather quickly, 5, 10, 15 minutes, or immediately afterwards. And it's usually short-lived, meaning it resolves in a relatively reasonable amount of time. But the more we see it, the more we see now that it may be delayed presentation, 15 minutes later, an hour later, a couple hours later. So I've had times now where I see it where they had some transient symptoms for a few minutes. They didn't think much of it. They thought things were fine. They woke the next day, went to school, and they start to develop headaches and problems with concentration. So that would be something where you'd say it even evolved over the whole first day. In terms of the changes that occur, they're thought to be physiologic changes. So they're not structural injuries that you would see like on a CT scan, MRI. They're more functional changes. I tell people it's a change on how it works rather than the structural injury to the brain, type of like a bleed or a skull fracture, something like that. Another one is that the concussion may or may not result in a loss of consciousness. So that's another common one. If someone says, well, I was awake, I'm fine, I don't have a concussion. That's not necessarily needed. A loss of consciousness is not necessary to define a concussion. So when we talk about the concussions, if we use those type of definitions, how common are they? The estimate is a wide variety. As you can see, 1.6 to 3.8. So obviously they don't have a real clear-cut answer how many there are because it's tough to define how many go undiagnosed, how many are seen in certain spots that aren't reported, but that's the estimate. It is 5 to 9% of sport-related injuries. So of all the sport-related injuries, 5 to 9% are thought to be due to concussions. And then 30% of concussions between the ages of 5 and 19 are sport-related. Meaning, obviously, there's other ways to get concussions, meaning they tripped and fell, car accidents, getting hit on the head in some other type of mechanism other than during an injury. Other incidents, when we talk about what are the sports that are most common causes of concussion. Football, wrestling, are two of the most common ones. For women's sports, girls soccer is a higher risk sport, and then you got men's soccer and girls basketball. So
Why not boys basketball?
there's some, that's a good question. This is using, I guess, prevalence data. The question was, why isn't boys basketball as high as girls basketball? And there's not a clear-cut answer. The thought is there something with the style of play that's involved that leads to more heads either hitting each other or hitting the ground? Is tough to say. That's just using the prevalence data. I don't think there's been a well-defined answer on why it's different. Other thing to notice, that game rates are higher than practice rates. So you could be practicing for an hour in soccer and play a game for an hour. The game play has a higher prevalence of concussions compared to the practice. So when trying to diagnose a concussion, you'll have your symptoms, which we'll talk about, the physical signs that you can see, not necessarily what they're reporting, but different things you can see. And part of those things that you will see would be behavioral, cognitive changes, or sleep disturbances. So those are all kind of common areas that occur with a concussion. First, your visible signs. So if you're on the sideline, a coach, referee, something of that nature, a loss of consciousness. There is a transient disturbance in brain function that resulted in a loss of consciousness that would lead you to believe that a concussion occurred. Others are slowed movements where they're slow to get up, slow to move. You'll see people walk off gingerly type of a thing. Poor coordination or balance, so that's the one where you see them try to get up, they stumble down or won't get up. A dazed appearance is something you'll have to see closer, but you can often see a kind of a glassy-eyed appearance. Or confused or forget play. So that's one we'll see sometimes. They'll go back to the huddle and they'll forget what the play was. Or they'll say, what was that play again? I can't remember, type of a deal. And then other players will notice that the person with the concussion is a little off. Symptoms that will be commonly reported by the athlete. You have your headache. That's probably the most common. Our early one, a quick one that's common, is dizziness or blurred vision will be another one. And you can see some of the other ones, a lot resulting in neck pain, pressure in the head. The other common ones are the ones that you can't really define, feeling in a fog, feeling slowed down, those cognitive type of questions or changes. Other symptoms, big ones that occur as they try to do day-to-day type of activity. Difficulty concentrating. So if they're having problems at school when they go the next day, that's a common one where they developed a headache or they were unable to focus. They weren't able to do as well with their school homework that night. Fatigue. As they do stuff during the course of the day, they're more likely to experience the fatigue as their brain has to work harder. And then the other stuff with the trouble falling asleep, the drowsiness throughout the day. The irritability, there's also the emotional aspect. The irritability is a common one. Whether that's due to the fact that they're not feeling well and they're just more irritable because they have a headache and they don't feel well, or the irritability itself, it's tough to say, but that's a common complaint that you'll hear from people in the family of the person with the concussion, that they're irritable. So you notice or recognize some of those signs or symptoms, or you see something on the field that's concerning for a potential concussion ahead, traumatic event. The concussion evaluation, first, your concussion is not necessarily going to be your first thing to consider. It's your first aid stuff, airway, breathing, circulation type of stuff if there is a very traumatic type of hit. But beyond that, the first things that athletic trainers that are covering the events or other health professional personnel may use what they call SCAT-3 or child SCAT-3, which is standardized concussion assessment. Those would be things that involve questions on how you do memory-wise, short-term memory, concentration type of testing, and ideally you have a baseline for that patient or that athlete before that occurs, and often organized teams will have that, but it's not necessarily the case, but it gives you an idea of where they're at cognitively. Included in that now, when they expanded the test on SCAT-3, it includes kind of balance and balance type of assessments. Single leg stance is a common one that they would use for that. Again, and then also in that evaluation, Imaging is kind of assess the need for imaging, whether you feel that there's an intracranial injury, meaning kind of the red flags on kind of the card that you have, which would be single-sided weakness or symptoms that are on one side more or the other, a rapid worsening of symptoms, persistent vomiting. Those are things where you're saying there an intracranial injury that may require imaging. So first thing that I would recommend, I think that's pretty standard, is removal from the competition while you're evaluating the athlete. If a concussion is suspected, say you feel that they had some dizziness, they had a headache, generally you do not want to return the same day. And I would say that's pretty much a consensus on kind of guidelines, don't return the same day, mostly due to the fact of what we talked about earlier. The symptoms are developing, they don't automatically occur right away. If it's a concussion that's developing later on, you don't necessarily want to have them playing when their worst symptoms or noticeable symptoms occur later. Other things that you'll see on the sideline or you'll do at home would be regular monitoring to make sure that they don't deteriorate, that their symptoms are stable or improving, because if there's a rapid deterioration, that would raise the concern for a potential intracranial pathology. Part of the recognition tool, so on the pamphlet with the lanyard, there's some different things to kind of potential questions that you may ask. So the traditional, what's your name, you know, where are we, those type of questions, how many fingers am I holding up type of things have been shown not to be reliable. So these Maddox type of questions, you know, where are we at, what venue or what stadium are you playing at, what quarter is it, who scored recently, different things that are a little more detailed than just what's your name are found to be more effective in determining whether there's a cognitive disturbance or not. So those would be things to kind of consider when you're assessing a concussion or concern for a concussion with an athlete.
So is there a set of questions like that not related to a sports-induced concussion?
Not published along with the kind of the SCAT-3 stuff. So this form was recently distributed by the Concussion in Sport Consensus Statement. They do those every 4 years. They get together and publish this. So that is specifically made for sport, but the questions that I would ask for non-sport related stuff would be things like, well, do you remember what you ate this morning? Or what are your what did you do last night? Something different than the simple kind of what's your name and how many fingers type of deal. Other things on the recognition tool, when you talk about red flags, those would be the things that we kind of talked about when you may suspect an intracranial pathology. That's where you kind of think of more of an urgent referral process to potentially get imaging at a hospital. Questions so far on that? Good there. So treatment-wise, so if you suffer a concussion, know someone who has, these would be common treatment plans or common treatment, initial treatment plans. So the first is physical and cognitive rest is thought to be the most beneficial. So your physical rest is kind of sitting around. It's pretty boring. You don't get to run around. You don't get to jump around. You don't get to play your sport. It is a lot of physical inactivity, basically. And the other is cognitive rest. That's where outside of school you're limiting TV, video games, computer games, texting, something like that. Inside school, that would be kind of maybe staying home from school, doing half days, limit how much cognitive exertion you're doing. Personally, when I consider physical and cognitive rest, one of the better combinations of that I see is sleep. So early on, I encourage a lot of sleep. It's tough to get too much sleep early on following a concussion. The reasons we avoid the physical exertion or the cognitive exertion is those are thought to potentially aggravate your symptoms of the concussion, and then the aggravation of those symptoms can prolong how long you have the symptoms in general. So we try to avoid those when possible, especially early on. Ideally, for a common concussion that improves gradually with time, as we would expect it to do with the physical and cognitive rest, once they are completely asymptomatic with no symptoms whatsoever, talking about all those symptoms we talked about earlier, They do not feel they have any cognitive deficits. They do not feel they have any balance deficits. All those there, and the person evaluating them does not notice any of those deficits. They start what we'd call a return to play protocol. So this is another thing that's been established kind of with the consensus statements, that you can start that after being symptom-free for a full day. Another thing to keep in mind, say you do start medications or ibuprofen or Tylenol to help with headaches during your symptom period, that you need to stop those to be truly asymptomatic. You can't be taking medications to be asymptomatic. Most of the time, most patients improve within that first 7 to 10 day period. So that may be something where we would anticipate you have your symptoms, you do your physical cognitive rest, that improves, you start doing daily activities, you don't have any symptoms with that, then you could potentially start these steps. Now the return to play protocol is a graduated program. It generally starts off being completely asymptomatic. Step 1 is a light aerobic exercise, something like a stationary bike, a light jog, something of that nature. Step 2 is a sport-specific type of activity with a little more exertion. So that would involve some lateral movements, movements of the head. The third is a full exertional type of activity. So sprinting, weightlifting, something like that. And then you proceed on to a contact practice and then potentially a game. Now this is a minimum that was kind of used with this concussion in sport type of guidelines. It's generally thought to you could advance every day, up to as soon as every day, every 24 hours you can go forward. The other keys that we talked about, if you develop symptoms, say at rest you are asymptomatic, but you develop symptoms once you start sport-specific activity, you need to stop, get symptom-free, again for at least a full day, and start back at the step below. And then you can kind of proceed again. Here is kind of what we use in the office, kind of the step 1, step 2, step 3, kind of what we talked about there. There will be occasions when we put the line here that we need to reassess prior to starting contact, because that's when you're going to have your potential concern about another contact injury to the head or another traumatic injury to the head. So we kind of emphasize that other step starting back to contact practice. The other thing I would say with this is like I kind of mentioned earlier, a minimum. Commonly for younger individuals or individuals that have had multiple concussions, or you're gaining more concern on how they're doing, that will often try to add days to this step, where I'll say spend 2 days at each step or spend 3 days at each step to add a little bit more of a buffer between the time they had their concussion and they return to play. So that's kind of some subjectivity to this plan on returning to play. Another one of the things that I'll sometimes try to do, ideally, I would see the patient before they start the steps, meaning, oh, yep, you're asymptomatic, you're cognitively good when we test it, your balance is good, we don't have any emotional or behavioral problems, everything looks good. The problem, and then start the return to play protocol. That sometimes is not feasible, because then there would be one day where you'd say, okay, I'm asymptomatic, you're not necessarily going to be seen the next day. So often, if we educate the patient or the athlete, say, look, once you're completely asymptomatic, you do not feel you have any of these deficits, I do allow them sometimes to start the return to play protocol, but then I do reassess prior to starting contact, where I'm confirming what the athlete is saying, that they're truly asymptomatic, their balance is good, and their cognitive function is good. Questions with those return to play protocol stuff, how that works? Good term. Another aspect in the return to play, or another evaluation tool, is the neuropsychological type of test. These are kind of ways to measure cognitive speed, or processing speed, short-term memory, different reaction type of stuff. The reason this is part of the evaluation, there is some evidence that the cognitive improvement from a concussion can sometimes occur at the same time as their symptoms, as they improve. Sometimes it's beforehand, or sometimes it's after. So if they are still having cognitive deficits, obviously you'd want to know that before they return to play. So that's some of the reason or the justification for neuropsychological tests. Now the different aspects of this, when we say most concussions can be managed appropriately without, that's when you're talking, when you're assessing concentration, you're assessing memory kind of in the office, not necessarily on a specific form, but then that in conjunction with the patient reports, often you can allow them to return to play without mandating a neuropsychological test. So the neuropsych test, the two major types are, one is the traditional paper and pencil. This is with a neuropsychologist. It is a very detailed test. It's usually a couple hours of questioning both the athlete and the parents on how things are, and then it's often a couple hours of testing, where it's traditional testing for the athlete, following numbers in a pattern, trying to remember different things when you're interacting with the person giving the test. A more common thing that you'll see now, just out of convenience, is the computerized neuropsych. So IMPACT is what we use here. That is computerized neuropsych evaluation that's meant to kind of assess different aspects of their cognitive function. So IMPACT is one name, HeadMinders is one, CogSport. Those are all different variations of computerized neuropsych type of test. Why they're used is they are relatively convenient. It's not hours and hours of testing. They're relatively easy to give as a baseline, and then you can compare it later on. The big emphasis with the computerized neuropsych test, it is not specifically a tool to say, well, once you get these scores, we know your brain's fine, go ahead and play. It's supposed to be used as part of the picture or a tool or part of the puzzle in terms of when they're safe to return to play. So sometimes athletes will be like, well, my neuropsych test is good, my computer tests are back up to baseline, I must be fine. Well, that's not necessarily the case because of other symptoms and stuff that we're monitoring. Reasons we are cautious for the return to play, or the biggest reasons we pay attention in terms of making sure we feel that you're safe and upon return to this play, or upon return to play, is second impact syndrome. So that's what you would hear about on TV if someone is having symptoms of a concussion or have not completely recovered, get hit on the head again, the brain swells up, and they have some catastrophic type of injury. So often people would end up in the intensive care unit. Some people have died from that. So obviously that's a high risk type of thing that you want to avoid playing sports or activities or high risk activities when you are having symptoms of a concussion. The second one, when I talk about the significant worsening of symptoms or the increase in the duration, this is what I more commonly see. So if someone has a headache from a previous injury, they didn't think much of it, they haven't reported it, they keep playing, they get hit on the head again, and at that point their symptoms that they were having might have been mild, end up being severe, meaning, okay, their headaches are now all the time. They're having problems with dizziness, they light sensitivity, so it's significantly worse. And those are the patients that I feel are more likely to have a long duration of recovery, meaning many months, maybe 2 months, 3 months, rather than a traditional 1 to 2 week period. So that's just another reason, in addition to second impact syndrome, to not be playing with symptoms of a concussion, or to make sure you are completely recovered before returning. The traditional concussion return to play protocol, what we talked about with those steps, these are some other things that can affect that for me personally when I see athletes. So if they've had prior concussions, I do not necessarily say if you've had 4 concussions, you're out for 1 month automatically. I don't necessarily give time frames, though I become more cautious with the more concussions that you've had. Other things that become more concerning are that symptoms, if the first concussion is a few days, your second one's a couple of weeks, your third one's a month, your fourth one's 2 months, that's obviously a concerning pattern that's developing. So as they're getting longer and longer, that becomes more concerning. And are they getting easier and easier to get? Meaning those last couple concussions, I was like, I didn't even think I got hit that hard. I don't even know if they hit me in the head. It was just a shoulder bump. How am I getting a concussion easier than what you did before? That's also concerning. The other thing I consider is the potential risk of future concussions. So that's where you talk about those higher risk sports. If you have someone who's going to be playing football, wrestling, and lacrosse, that's a sophomore in high school, they obviously are going to have a lot more exposures or risk than someone who's doing golf, swimming, and cross country or something of that nature. So assessing that risk to say, well, you have future risks that you want to participate in the future, you may need to be a little more cautious to ensure that you're able to do those in the future. Other aspects, so if you do unfortunately have a prolonged recovery, so you didn't get improvement in a relatively quick manner in those first 1 to 2 weeks, here's some other things that we sometimes consider. One is there is some pharmacological type of stuff or medicines that we do to try to help with symptoms. Most of those involve helping with headaches, helping with sleep, helping with focus, where there's different medications that can help with the symptoms. They have not been shown to speed up your recovery. They're just more or less to help with your symptoms while you have those symptoms. Another is aerobic threshold conditioning. So when we talked earlier about physical rest early on, that is true. That's thought to be the most beneficial. But somewhere normally around the 3 to 4 week time frame, that is thought that some aerobic exercise can be helpful. So when they do the studies, when they get into that 4 weeks, they divide them up into 2 groups. The people that do some aerobic exercise in a certain type of pattern get better sooner than those that did not. So it's not permanent physical rest. There is some aspect of aerobic condition that we eventually do. The vestibular therapy, that's where we're talking about different inner ear signals that's sent back to your eyes as well as your brain on where your head is in space. So sometimes doing different drills or different exercises at home to allow your brain to adapt to those vestibular changes that were experienced from the concussion can be helpful. And then the last is some cognitive therapy. So that's if they're having problems with concentration, focus, this is a way to both help them become accommodated or make some changes that make it easier for them to do their schoolwork, participate in their schoolwork, doing their homework and such.
What was the picture about on that slide?
The vestibular symptoms. So those would be common vestibular complaints. So when we test vestibular, our question is what are the pictures on the slides? When they're talking, it looks like a head's going side to side, up to down. Those are going to be movements that your vestibular symptom is sending signals back to your brain knowing where the head is in space. So if someone turns to the right and they feel like the room is literally spinning, not like they're going to faint or pass out, that the room is spinning, those are a vestibular symptom. So those are where you would get those type of things, up or down, head turning side to side or laying back. Something of that nature can cause those vestibular symptoms. And then common type of vestibular stuff would be slowly following a finger, doing those, kind of practicing those at home. Focusing on a specific object while moving your head. Those would be different things that are kind of testing your vestibular function. So say you end up at a point where you have not gotten better the way you would expect. You've tried some different things early on, and there's some concern about postconcussive syndrome. So this is kind of the prolonged recovery or prolonged symptoms that you can get from a prior concussion. There's no specific one definition. There's different groups to use it different ways, but I kind of see it as persistent symptoms of a concussion that are no longer improving or did not improve in the expected time frame that we would think. So I wouldn't say someone has postconcussive syndrome 4 days after a concussion. I would expect that to occur from the concussion and those to improve. But if you're saying, well, it's now 4 months, oh yeah, that did not improve the way we'd expect it to, and then I often refer to those as postconcussive syndrome. When that occurs, what we had talked about with the other therapy options, if you have that symptoms that are lasting longer, one thing we like to evaluate is there other conditions that are mimicking concussion or the concussive symptoms. One of those is depression. So they are depressed, they then have problems with sleep, their mood's down, they're irritable. Those would be things that can mimic symptoms of a concussion. So we evaluate for depressed mood sometimes. The chronic fatigue and pain. Is there something with the neck, trigger points, something like that that is causing the persistent headaches, and that goes along with cervical injury. The other is the vestibular dysfunction. Did they have an injury that occurred to their vestibular symptom at the time that causes the persistent dizziness, the persistent blurred vision or double vision? That goes along with the visual dysfunction. Often your vestibular symptom is going to interact with your eyes to maintain focus on a specific object. Obviously, if you're having problems with that, objects are going to appear blurry, or any combination of those. Long-term risk. So when we talk about athletes, say you've had 3 concussions, 4 concussions, 5, 6, 7, 8, however many it would be, and you start getting concerned about long-term consequences of concussions. One that had been recently in the news is the chronic traumatic encephalopathy. So this is often referred to as or has the signs of memory impairment, depressed mood, poor impulse control. So these are former athletes that you say sometimes hear in the news that have either committed suicide or other type of unusual behavior. They have found evidence of chronic traumatic encephalopathy in some of those athletes. Another one, the chronic neurocognitive impairment, just meaning that they're having poor memory type of skills, processing skills that are permanent. Now, they have seen associations between these concussions as well as even subconcussive insults, meaning someone who hasn't had a single traumatic injury that resulted in a concussion, but multiple mild hits that are subconcussive, meaning they didn't cause a concussion, but still can be associated with those two conditions. Right? There has been no definitive cause and effect identified, and that's mostly because the people that have chronic traumatic encephalopathy now, if they had their concussions over the past 20 years, we didn't keep track of them 20 years ago. So this is something that will be developing over time. I'd say over the past 5 to 10 years, there have been reasonably good records, at least in terms of reported concussions in high school, college, that are kind of kept in terms of the numbers they have, and we'll get better ideas on this long term. Concussion prevention. So obviously that's something we'd all be interested in. First one is the mouth guards. There is no solid evidence that mouth guards have been shown to prevent concussions. There was one study of custom mouth guards that did show a small decrease in concussion, but it's been a single study to this point. It hasn't been reproduced. Most of the studies, or the vast majority, end up not showing a defined or significant reduction in concussions. Now, that being said, I like mouth guards, mostly because orofacial injury and dental injuries, they do a very good job of preventing those. So if someone were to ask me, well, are you going to have your kid wearing a mouth guard when he plays basketball? I'd say, yep, in case he gets elbowed in the mouth, missing teeth, different type of injuries there that they have been shown to be effective. Next is the helmets. It would stand to reason that helmets are effective in helping with lacerations, different injuries to your scalp and skull, and that is the case. There is good evidence that they help prevent those injuries. We do not have evidence that they reduce concussions either. Now, you would say, well, it would be tough to study that at this point, meaning you're not going to get many volunteers to play football without a helmet to study it. But we don't have any evidence for it. But the idea with the helmets, or at least when they try to measure helmets for how effective they are or not, they measure how much it reduces impact forces, how much it reduces rotational type of forces, those type of things. And it's thought that that may reduce the amount of concussions you have. But as we kind of talked about earlier, the type of blow or the force of the blow is not the only determinant of whether you get a concussion or not. But you would think that there may be some reduction in those if you can reduce those forces, rotational and impact type of things. The big thing with the law, which we'll talk about next, probably one that I think is most appropriate, is helping educate specifically coaches and different adults or referees that maybe 15 years ago said, well, it didn't matter 15 years ago, that was just a bell ringer, I'm fine, it's no big deal. And that may be the case for them, that they are fine, but there's other athletes that that wasn't fine for. And that's why we kind of have this law. I still have occasions where I am surprised on what kids end up playing with, where they've complained of a headache, they're dizzy, some other issues, and they're like, well, we think it's something else, go ahead and play. So that's what this law is ideally trying to do, help educate coaches, different people involved with young athletes in their sports. Other educational type of tools that you can look on, NCAA's big, CDC's good, the Healthy Ohio program, that's what's new with this concussion law that was recently passed. And the NFL is getting involved with it, and obviously they're one of the higher profile ones that have this concussion in the news. So obviously they're trying to get out in front of the concussion type of talk stuff, so there is reasonable education type of material there at those websites. So the law, April of last year is when it started. The basis of the law, or the highlights of the law, the student or the athlete's parents, it doesn't have to be a school student, it can be club sports type of stuff as well. Parents or guardians must have received a concussion and head injury information sheet. And I think there's a sample of it, excuse me, a sample of it in the folder. Is that correct? So that is what you may get from a club or your child's sport team or your own that you participate in, that they will give you that handout that does involve or educational type of tool involving concussions. Other one, coaches or referee for an athlete that exhibits signs or symptoms of a concussion must be removed from the game. So if some injury happens, the athlete's dizzy, complains of a headache, you notice they're slow, confused, some type of injury like that, they must be removed from the game at that point. There is no return to play the same day the athlete is removed to play. And that's mostly due to the one thing we talked about earlier, that you can have a delayed presentation in the symptoms. And two, that is also for safety, meaning if the athlete says, well, yeah, my headache's fine now, and okay, that's good enough, you're back in. It's more of the idea to avoid that immediate return back to play. Other is the athlete is then unable to return to play until they have written permission by either one, a physician, or two, an authorized healthcare provider authorized by the school or club sport. So that's the situations, say you have an athletic trainer at a high school and they're working in conjunction with the physician. The physician calls up, yep, check this, those are good, I've seen them, you can go ahead and have them return to play. So it doesn't have to be a physician, but it has to be an authorized provider. Those would be different things, whether it's someone that is, athletic trainers are by far the most common. It can be kind of nurse practitioners, physician assistants, stuff like that as well. The law also requires concussion training for coaches and referees. So that's those two different options, one being an online training course or the pupil activity permit. So that's a school-based one that's often used for teachers. That's one where you'd go to a session, something like this, go over the law, what you need to do, different things with the concussion, and that would qualify. Or the online training course, which is operated either through the National Federation of High School Coaches, or I believe the CDC also has a website that qualifies. Oh, there they are. So those are those two sources or resources for those online training courses. Here we're talking about that written clearance from the physician or the licensed healthcare provider. So there's some examples of people that can do it. So a person that's under the supervision of a physician, athletic trainer, collaboration, so a physician assistant, nurse practitioner, or something that's been discussed with the physician, they could potentially then return to play having that written permission from that licensed healthcare provider. Questions on that law with that there? So it's something you'll see about for at least for the future here, especially if you're any club sports, like I said, high school type of stuff, any school type of organized activities will have that. We'll quickly go over some common school accommodations. So if you have someone in school, say you have that concussion, what are some common things schools can try to do to help, or one of the things you can try to do to help them in their recovery? What we talked about earlier, that cognitive rest early on. So generally a day or two may not be unreasonable to keep them home from school to allow them to rest. Some people don't need the days off school and they go back and they may have some mild symptoms, and I think that's okay. But individuals that have some significant symptoms, I kind of refer to it as, if you are going to school and you're going to lay your head down and sleep and not be able to pay attention because your head hurts, you'd be better spent sitting at home sleeping than you would be trying to go from class to class just to be there. In conjunction with that, so sometimes people say, how do you know they're just not skipping class and they want to avoid something? Generally, you can tell with a concussion because they're uncomfortable and they have other symptoms. But we also try to avoid other type of stimulus. That's what we talked about with the computers, TV, texting, stuff like that. I often consider half days upon returning to school. Either it be the same half day or alternating half days, meaning so you don't miss the same classes. If you go in the afternoon, that may allow you to sleep more in the morning, which I often encourage to get more sleep, as what we talked about earlier. Or kind of make that according to the day of the class, or parts of the day that they need to for their classes. If it's the middle of the day or the afternoon, they can adjust that accordingly. We will often do some things to help them avoid important tests, assignments, things like that while they have the concussion, because one of the symptoms is cognitive impairment. They may not be able to do it as fast. They may not be able to do it as well. We often talk about breaks from light or noise from the classrooms. So the last 10 minutes of a class, they may go down to a quiet room and take a break. If they have problems with concentration, the upfront seating. We don't do the phys ed class with the running around, jumping around. And then the last one, we always have a note in case they need one that they can bring water with them to class, milk, juice, whatever it is that they like to drink to stay well hydrated, as that can help with headaches that are sometimes associated with the concussion. So here's a sample of the form that we kind of use in our office. You know, we talk about the brain injury, and then some things that we sometimes use. Fluids, the break, the things we talked about, no recess gym, whether they can take some medications, are they doing school at all, and if they are they doing half days? Those type of things that we would hand to the student upon returning to school. Next would be there is a step up from traditional just simple plan or simple thing that you can do with those recommendations. It's called a 504 plan or a 504B plan. This stemmed from the Rehabilitation Act of '73 due to the mental impairment from the concussion. These are things that involve meetings with the school that are created to help with their performance at school, both with their allows additional time where there's a set schedule, that maybe certain classes are postponed completely or certain assignments are postponed, so it's generally written out. These are more frequently done when I expect a long duration. So it's been a month and it's not looking like it's going to be anytime soon when they're not having any symptoms. We often will make up a 504B type of plan. Most of the time now, over the past few years, schools have been much more willing to come up and follow just simple recommendations. I don't do them as much as I did 3 years ago, mostly because most schools have plans in place now already that mimic what we would do with a 504B plan. Other reasons are ways to kind of help with different aspects of a concussion. So if we feel that their processing speed is slow, here's some things that they can try to do for that. So if you have someone or know someone who has those concussions, these are recommendations that are sometimes spelled out. As well as the memory deficits, where you would have a monitored plan or something of that nature where they're keeping track of what they're doing each day. Someone's making sure that they're remembering everything that was said in class, written instructions as well as the verbal, so notes, prepared notes that can be given to the student. Attention deficit type of stuff, again, this is the upfront seating, frequent breaks, visual prompts where the teacher knows that they're having some focus concentration issues where they can often interact with them more frequently. And then the organizational stuff. This is that to-do list type of thing that we talked to, that the teacher may have made out for the student to allow them to make sure they're getting the assignments, their stuff done that they may not do for other students or they expect the other students to be able to do. Others being, so the recommendations we do frequently are almost always for our concussions. We have the 504B plans or 504 plans that are maybe something that's an expected longer recovery. Then we have the IEP. So these are, again, long duration is expected where we want to come up with alternatives to their school. So these often involve homeschool instruction or home instruction in conjunction with the school, a specific plan on which classes they can do, which ones they can't, that get a little more involved than just simple recommendations that the school can do. Again, these are relatively infrequent. This do involve input from both the parent as well as the school. Again, a written plan that requires regular meetings between the parents and the school. Oh, well, what happened there? These are some common sources. If you wanted to look them up, you can obviously get basically all these online. These are different things in terms of accommodation stuff with school. This is the consensus statement, which is the most recent one. American Medical Society, so that's the basically the Society for Primary Care Sports Medicine Physicians that commonly interact with concussions. And then you have kind of your different organizations that put different information out. So that is the basis of our concussion talk. Any questions, things you've always wondered about with concussions that we're willing to answer for you? Anything? Seth, anything for your assignment?
Are they doing anything like at pro levels or college level or high school or even like the lower levels? Are they doing anything to like prevent concussions?
The question was, I got to do this. Question was, are they doing anything at the professional level, college level, something to prevent concussions? They say that the professional level and even the college level, they're doing a lot of research in terms of the helmets to see if they can find something helmet-wise that will reduce their concussions or the rates of their concussions. Things that they would be doing, they're putting accelerometers in helmets now to measure how big of an impact it was it rotational, where did they get hit, those type of things to see if they can make rule changes to reduce the amount of concussions they have. So that's the most common one that you hear about, and that's the one you hear people complain about, like why is the kicked off moved here? And there's different things, the spearing type of stuff with the penalties, with the rule changes to limit the risk for those concussions. So rule changes is probably the most prevalent one they're doing. They're trying to do stuff with the equipment, but that seems to be very difficult to make simple changes that we know provide some benefit. Those would be the ones that I'd think of that they're probably doing most often.
Are they teaching them like having to like a different way to play, like don't hit like from head to head?
So yes, so that would be one that's probably, or the question is, are they doing anything else in terms of the type of play or way they play? So yes, so for high school specifically and below, the NFL starts, I think they call it their heads up program. So trying to teach tackling techniques that don't involve the crown of your helmet. One, that hurts with concussions, and two, that also involves neck injuries. So it's kind of a heads up tackling type of instruction they're trying to do. And that would be the one that I'd say that they're trying to do, the tackling technique type of stuff. They're also trying to do different things with coaches to say, look, this drill that you did 20 years ago where you just lined two people up and had them ram each other as hard as they could, maybe that's not necessarily a good idea. Let's come up with alternative drills that you can do that may be a little safer for the athlete. So I'd say that may be another thing they're doing, kind of coach education, changing the drills or different things that they would do. Good? Go ahead.
Curious about whether there is any studies been done about different regions of the head, and whether there seem to be different severities of concussions based on the point where the trauma was.
So the question is is there studies that show differences in severity depending on where they were hit or what regions of the brain were affected?
Even likelihood of it.
Or the likelihood, yes. So there is reasonably good evidence that where you get hit will make a difference on whether you get a concussion, just statistically. They go back and watch, 5 seasons of football, try to do the best they can to see where they were hit and whether that resulted in a concussion or not. So at this point, things on the top of the head seem to be worse than things on the sides or the back. The rotational type of component, they don't really have a good grasp of. That's what they're trying to do now with the accelerometers. So the location, it does seem to matter, with the top of the head being worse, or kind of the front here. 2 was what areas of the brain would be affected, or are they concussions affecting certain areas? So some of the studies that they're doing now that aren't involved in day-to-day care would be something called a functional MRI. So it's basically an MRI that measures the activity of the brain, or what's going on metabolism-wise, or where the activity is. And different areas will light up with different types of injuries. And there seems to be some correlation with what type of symptoms, or correlate with where the symptoms are. There may be some aspect of that. The issue with the functional MRI is there's just not enough numbers and data. We don't know what it was like beforehand. MRIs are obviously expensive to do, and it's tough to get the studies for it. But there is stuff that they're doing to try to determine what areas of the brain are affected and what that means for the concussion. It's mostly just in research now. Or big research centers where they have functional MRIs to do this.
I did think of another question.
Yep.
Do you know what Dayton Children's is doing for their baseline concussion screening? You mentioned some of
The question is do I know what Dayton Children's is doing for their baseline screening? So yes, that is another variation of a computerized neuropsych evaluation. So like I said, IMPACT is a common one that's based out of Pittsburgh. CogSport is another one. That's another one that I believe is the one that they're using, and it's kind of based out of Australia, I believe. But there are different types of tests. One test would use like playing cards and trying to remember orders, or did you see this one before, or how fast can you place them in an order. IMPACT tests will use different things like different shapes and try to correlate those with certain numbers. Can you remember which number was correlating which shape? Those type of things that occur, they're similar in that they're a computerized version of doing different processes that you would do.
But they're primarily the neuropsych test?
Yes. So
that which you said, if I understood you correctly, that it's really to be used in conjunction with other evaluations.
Right. So the idea with that would be is if you have a computerized neuropsych test, even if you have a baseline, after you get a concussion, the idea would not be, oh, I'm going to take this test and make sure I have the same score I had before, and if I do, I'm fine. Meaning we want to also look at balance type of assessment, symptom assessment type of thing. So that's where that comes into play. It is sometimes nice to have because that is likely a more detailed evaluation of their cognitive function. Now the issue that I have in terms of the computerized neuropsych test is one is they're not perfect in their reliability. Meaning if you took one today and then you took one a week from now and you didn't have a concussion, you would not get the same exact score. There would be some variability between those. And 2 is the cost. If we're going to be doing cost for this, I mean the time hours and the costs associated with doing the test, that's another concern that I would have in terms of the reliability and the cost associated with them. But I mean, they're nice to have when you can eliminate those or you take those into consideration.
I guess I'm curious if you're thinking about children in particular, how those can be designed to accommodate for normal human development.
Right.
So if your baseline is 3 years ago,
Right.
can you expect that child, and I don't know the papers, I don't know.
Right. So the question is developmentally, is that going to follow the athlete over the course of years with the neuropsych? The question is no, it doesn't exactly correlate. So impact specifically, they'll say, we want you to do your baseline testing every 2 years. They have studies that say we have studies that starting at 12 or starting at 11, we have normative data for other 11 and 12-year-olds that have taken this test that you can compare it to. The other different ones will have different ages where they say, well, ours is good down to this age, or ours is good down to this age. And that's what they're trying to do. And then you take repetitive, or on a series, you take another baseline test every 2 years, or whatever each testing computerized neuropsych test program recommends. Now, that's the other issue when we talked about that reliability. Is the variability from test to test the same, or is it very little? But as you get further away from the previous baseline, there's also evidence to say that your variability increases. But again, they're not perfect tests. You kind of take that you take that in consideration when you get the test or when you follow up with it. But no, they do an additional baseline test over time.
Are parents doing anything at the younger age to try to convince their kids not to play sports due to the amount of concussions that we've seen the last couple of years of increase? I guess is one on.
So the question is parents, or do we know of parents that are changing either their kids' behavior or their behavior, allowing them to do certain sports due to the concussions? Now, I have not seen specific evidence to say that's the case, even though I see it in the office, meaning I will see a 9-year-old playing pee-wee football and has his first concussion, and parents say, all right, that's it. You're not going to play tackle football until you're 12, or something of that nature, where obviously something related to a concussion has led to that. Or their brother and sister is now not going to be playing tackle football until a certain sport. I don't know of statistical evidence of that, but I see it in the office or on my own just interacting with people, that they're more likely to delay the start of a higher risk type of sport like tackle football, wrestling, different soccer stuff, or they're more cautious with their returns from concussions. Any other questions? If you have them off camera, I'll still be here a few minutes. But that's it. Thanks for coming.